Hi, I'm Dr. Mohammed Umar. I'm an interventional spine physiatrist in the Department of Orthopedics. I'm here with our emergency medicine resident, Kingsley, who's going to help us demonstrate a physical exam for the cervical spine and the lumbar spine. We'll start with the cervical spine exam. Oftentimes patients will complain of neck tightness or some sort of radicular symptoms, which we'll get into. But basically what you want to look for is any sort of bogginess or warmth or any sort of swelling or any sort of tightness. So oftentimes you can just kind of palpate along the cervical paraspinals, the levator scapula, trapezius muscles on both sides, and patients will complain of any sort of tightness or pain as you're palpating. So you want to look for any sort of like asymmetries to see if if one side is tighter than the other, or if one shoulder is sloped versus the other. You can kind of get a good feel of what the patient is complaining about and what that means clinically in terms of diagnosis and treatment. Next thing you want to do is check the range of motion. Patients complaining of pain, often they may have limitation of range of motion in cervical plane. So you start with cervical flexion. You can just tuck your chin towards your chest. So typically it'll be about 30 degrees or so. If it's less than that, again, they may be due to a restriction or tightness or some sort of cervical pathology. And then you can also have them extend as well. That gives you an idea what's going on as well. Go back, and then you can have the patient rotate, and usually about 45 degrees, 45 to 60 degrees. If the patient has any limitations, we'll rotate the other way as well. If the patient has any limitations in range of motion, that may be due to tightness of the scalene muscles or any sort of cervical paraspinal muscles that might be limiting the range of motion. Okay. The last thing you can do is have them side bend, so to try and move your ear towards your shoulder. Obviously, they can't go all the way, but if there's any sort of limitations, again, that can indicate some sort of a musculoskeletal pathology. Last thing we want to do for the cervical spine is a Sperling's maneuver. It's something you see very commonly in the clinic as far as cervical radiculopathy. Patients will typically complain of anything ranging from numbness, tingling, a burning, a pain, an ache going down their arm. Sometimes it can also present as a headache. So if the muscle is tight on one side or the other, and it can cause headaches, and that can be due to cervical radiculopathy from a pinched nerve, a herniated disc, a herniated or a protruding disc that might cause these symptoms. So typicily, you can do it in a couple of different ways. What I like to do is I extend the patient's arm out, and then I push down, and I kind of point towards, tilt their head towards the affected side. And if they have any sort of reproduction of symptoms, that's very important. If they feel that it's causing the same numbness, tingling, pain that they're describing, that would be indicative of a positive Sperling's maneuver. And then we can do the same thing on the other side. And push down. Generally, you don't have to push down too hard. Typically, even the slightest bit of pressure can reproduce those symptoms. Okay. So for the lumbar spine, again, patients will complain of some sort of muscle tightness. They might complain of a knot in their back. They might even feel something, and you can kind of palpate. So basically, palpation is very important, similar to the cervical spine. Is there any sort of bogginess or any sort of swelling? And sometimes you might feel like a knot. Patients are concerned, well, what is this bulge? But typically, it's muscle tightness. Okay, and so you palpate along the spine, and you see if there's any sort of discomfort or reproduction of symptoms. While the patient is standing this way, I also like to do what's called facet loading or a Kemp sign. Basically, what I do is I have the patient extend their back, and I twist their body towards one side or the other. And if they have any sort of positive sign or any sort of pain with this extension, it can be indicative of a facet arthropathy, which would be typically associated with axial localized low back pain. Okay? And since the patient's still standing here, what I'll also do is I'll also examine the sacroiliac joint. The sacroiliac joint, typically, clinically, it's more commonly seen in women in their 20s and 40s. Typically, it's worse when you sit for a long time. It typically can go into the buttock and thigh region. I kind of find it to be more of a clinical diagnosis, meaning if you're pressed there and it hurts, it's probably a sacroiliac joint dysfunction. You seldomly, I mean, you still see it, but you typically don't see a sacroiliac joint pathology on X-ray or MRI unless it's really, really advanced. So with sacroiliac joint pathology, typically it's more commonly seen in women than men because of the shape of the hips, but men can get it as well. Typically, it can be it's mostly in that lower SI joint area. It can also be typically worse with prolonged sitting. It can typically radiate into the buttock and thigh region. It can present very similar to an L3, L4 radiculopathy, but it's more of a clinical diagnosis where you press in that sacroiliac joint region and they'll complain of pain. So typically, you feel for the iliac crest, and then you kind of just palpate a couple of finger breadths down, and you palpate in this area. Typically, patients will complain of pain. And often, what I always advise patients is when you're doing this sort of exam, always ask the patient's permission, or at least let them know what you're doing. Don't just palpate, below their belt region without asking. At least tell them what you're doing. So typically, also when I do the exam, I'll start with the lower back exam. I'll palpate here, and I'll say, okay, I'm going to press a little bit lower, and then I press towards the sacroiliac joint region, and then they'll tell me, hey, that hurts or that doesn't hurt. The other exam that you might want to do here is the piriformis exam. So the piriformis muscle, typically, the piriformis nerve goes through the piriformis muscle, and that can cause pain typically into the calf and ankle area. It can present similar to an L4, L5 radiculopathy, but again, it's a kind of clinical diagnosis where the patient's complaining of pain worse with sitting, and you palpate there, and you see if they have symptoms. So again, same thing. I'll say, hey, I'm going to press a little bit lower. So you press start here, and you say, I'm going to press a little bit lower, and then you press into that piriformis region. And again, you don't even have to press too hard. Patients will say, oh, this hurts, or they'll say, yeah, this, or they'll point to that region and say, yeah, this is the region that hurts. So that's how you do a quick piriformis exam. So you also want to check range of motion when typically somebody's complaining of low back pain. How much muscle tightness and what's going on that's limiting their range of motion. First you can try lumbar flexion. So what you want to do is have the patient bend forward and try and touch their toes. And try to keep their knees straight as possible. And you'll see if there's you can come back up. If there's any sort of limitation in range of motion, typically patients won't be able to reach all the way to touch their toes if there is some sort of lumbar symptoms, some sort of lumbar musculoskeletal pathology. If there's a tightness in their lumbar spine, they won't be able to do that. And then so you have them bend backward as well to check lumbar extension. Typically, it's about like 30 to 40 degrees. If you see a pathology, it will be less than that. Often, sometimes you got to also put it in relative to the patient themselves. A younger patient will have better range of motion than an older patient, so you have to kind of put that into perspective as well. So that's the lumbar range of motion. Have a seat. So the most common thing you'll see with the lumbar spine is, as far as the musculoskeletal exam is lumbar radiculopathy. And so there's a couple of different ways to do that. There's the slump test. There's the seated straight leg raise, and a supine straight leg raise. So the slump test, basically the patient is their neck is in cervical flexion, okay, and then you're basically going to lift their leg up. So this is a full leg. Lift their leg up, and then you're going to dorsiflex the foot, and you should note where they have pain. If they have a positive straight slump test, or if they have a lumbar radiculopathy, they'll complain of reproduction of the radicular symptoms. And radicular symptoms, again, same thing with the neck. It can be any sort of numbness, tingling, burning, aching, or all of the above, or just one or two of the above. So that's one of the most common tests for that. The other quick way to do it is a seated straight leg raise. So what I do for a seated straight leg raise is kind of the most common test I'll do. It's a very quick way to do it in the clinical setting. I'll have the patient seated, and I will actually lift their leg up like this slowly and see if they have pain. So oftentimes when I do this, the patient will subconsciously extend their back because they're trying to avoid that flexion of the lumbar spine to avoid the radicular pain. So what you want to do is you have them lean forward as you're doing it to reproduce that 30 to 70 degree angle to assess the positive test. Sometimes you may not even realize, as if you're just doing it without looking at the patient, they might be bending backwards, and you only get that 10-20 degrees that might give you like a false negative. So you want to have them like bend forward as you're doing it to see if they have reproduction of symptoms. Okay, so the other way to do a straight leg raise is have the patient supine on the table, and then just raise their leg up. I like to either stabilize the other leg if there is hamstring tightness, or stabilize this leg and lift up, because you don't want them bending the knee and losing that straight leg straight leg position. So typically you go between 30 and 70 degrees and see if there's a positive sign. And a positive sign would be, again, reproduction of radicular symptoms, any sort of numbness, tingling, burning into their leg. The other thing you have to watch for is positive hamstring tightness, because that can present similarly, and they'll say, ow. So typically they might feel it more if they're, if you go past the 70-degree mark, you're basically stretching their hamstrings. And often you'll find that patients that have back pain will have hamstring tightness, because or people that have any sort of radicular symptoms will have hamstring tightness, because whenever there's an injury to the bone, the nerve, the tissue, the muscles in the area will tighten up, which includes the hamstring muscle. So you have to be mindful of that and see where exactly the patient has positive findings. The other thing you have to look for with any of this sort of things is that are patients giving you false positives. If patients are trying to tell you that, oh, I have this pain, but maybe there's some sort of they're malingering or some sort of other gain, one thing you can kind of do is distract them while you're doing the exam. Whether it's like supine or seated, I often like to do is I ask them about something else, or I ask them about their pain levels, or ask them about how long it's been, or what kind of work they do while I'm doing the procedure. And I'll say, hey, so what kind of work do you do? How long have you been working there? And I'll see it. If they say ow, or if they flinch, then I'll know it's a positive sign. If they don't say anything until later on, or if they say if they start saying that it hurts and when I'm only at 10 degrees, it's probably not a positive straight leg raise.